and subscribe to our YouTube channel. And on the 12th of June, we are going to have a very special session with Dr. Gilvernovsky, the CICU, the Cardiac Intensive Care series. We are going to talk about the changing the status quo for hypoplastic left heart syndrome. A lot of nice speakers. This is going to be a very good long masterclass. We are planning to do a 3-hour session covering a lot of topics with this very particular and important disease of our field. On the 10th, 11th, we are going to have the Toronto Cardiac Symposium talking about the Tetralogy of Fallot. Please join them. Congenital Heart Academy is happy to be a partner. On the 12th, if you are a surgeon, we are going to have this hands-on training with 3D printing. This is going to be very nice. Unfortunately, the registrations are closed so far, but this is something that's going to be nice. Sasha is one of the proctors to try to teach online how to have some tricks and tips for this surgery for Tetralogy of Fallot. I'm sure it's going to be very nice using the 3D technology. And in 14th of June, Dr. Silverman continues his series that correlates morphological images and echo. He's going to talk about functionally single ventricle. It's going to be very nice. And in the end of the month, we have our meeting of the fetal cardiology. This time is going to be our colleagues from Italy. If you missed yesterday, it was our colleagues from Germany. They talked about a lot of interesting topics. Please take a look on our YouTube channel. And this one that's going to be on the end of next month is going to be awesome as well with the Italian colleagues covering topics with fetal cardiology. Now we are going to start with Dr. Anderson and Dr. Diane Spicer and all the amazing panelists that we have today for discussion. So please type your questions on the Q&A chat box, and we are going to have a lot to talk in the end of the session. Thank you, guys.
Well, good afternoon again to you, ladies and gentlemen. So you will all know, those of you who were here last week, that today we are continuing our discussions of double outlet right ventricle. And what we emphasized to you last week is the double outlet right ventricle is no more than a grouping together of all those hearts in which the two outflow tracts in their greater part are supported by the morphologically right ventricle. So what we emphasized to you last week is that this lesion comes in various guises. And here I've listed just some of them. You can find it with any atrioventricular connection. You can find it with different arterial relationships. We're not going to be concentrating on those variations today. Rather, we're going to be looking at the major differentiating feature, and that is the location of the interventricular communication. But you should remember, on the basis of what we've said already, that double outlet right ventricle cannot coexist with another ventricular arterial connection. So it's a no-no to talk about double outlet right ventricle with transposition. In most instances, when people nowadays use this terminology, they mean no more than double outlet right ventricle with an anterior aorta. So they should say what they mean. Because as we've been discussing in the last few weeks, transposition nowadays should be defined on the basis of discordant ventricular arterial connections. So today, we're looking at double outlet right ventricle. Those of you who were with us last week will remember that we discussed the controversies. And we pointed out that most of these controversies are outdated. I hope no longer anyone believes that you need bilateral conuses or bilateral infundibulums in order to diagnose double outlet right ventricle. And I hope by now you've come to realize the double outlet ventricular arterial connection can coexist in the setting of Tetralogy of Fallot. But there are ongoing controversies in this setting, and that is what we are going to be discussing with you today. Because last week I pointed out that when you take the various forms of double outlet right ventricle, you can separate them into a series of spectrums. But controversy remains as to how best to divide those spectrums. So we're going to look at that. But then we're going to concentrate on how best to describe the channel between the ventricles. And is it really best described as a ventricular septal defect? We don't think it is, so we'll try and substantiate our viewpoint. But before we do that, let's return to the outdated controversies. Why do we no longer insist that bilateral infundibulums are needed as an essential part of diagnosis? And in part, that's because, as we're going to show you very shortly, you can have patients in which both arterial trunks unequivocally arise in the greater part from the right ventricle. And yet there is fibrous continuity between the leaflets of the atrioventricular and arterial valves. Equally importantly, you can come across hearts that have concordant, or more frequently discordant ventricular arterial connections, transposition, in which there are bilateral infundibulums. And in that setting, I hope you would not use the presence of those bilateral infundibulums to make the diagnosis of double outlet right ventricle. So let's now look at these situations which show that we cannot use bilateral conuses as one of the diagnostic features for double outlet right ventricle.
This specimen has a double outlet right ventricle, and the anterior free wall of the arterial trunks and the right ventricle have been previously removed. The arterial trunks exiting the ventricular mass are side by side with the aorta to the right of the pulmonary trunk. If I tilt the ventricular mass and we look down into the aortic root, we can see that the aorta is clearly committed more to the right ventricle than the left ventricle, confirming that we have a double outlet ventricular arterial connection. The pulmonary outflow tract is not stenotic, and this outflow septum separates our aortic and pulmonary outflow tracts. The mitral valve and the aortic valve are in fibrous continuity with one another in the left ventricle. So this confirms that you can have a double outlet ventricular arterial connection without bilateral subarterial infundibulums. The next case also has the free wall of the aorta and right ventricle removed, and we're looking at the aortic outlet. The aorta is anterior and rightward of the pulmonary trunk, in this case with transposition. The tricuspid valve is here, and in this case we have anterior deviation of the outlet septum causing subaortic stenosis. The aorta is supported by a complete muscular infundibulum. Looking at the left ventricular outflow tract, the pulmonary valve also is supported by a complete subarterial muscular infundibulum. You can see where the mitral valve and the pulmonary valve are no longer in fibrous continuity secondary to that subarterial muscular infundibulum. So this heart clearly has the ventricular arterial connections consistent with transposition, with the aorta arising from the right ventricle and the pulmonary valve arising from the left ventricle. Both arterial trunks are supported by complete muscular infundibulums.
So let's come back to Tetralogy of Fallot. What we've emphasized again and again is that what we are discussing today, double outlet right ventricle, is defined on the basis of the ventricular arterial connection. It is quite different with tetralogy because we define tetralogy on the basis of its phenotypic features. And that means that the two can coexist. What do I mean? We can have Tetralogy of Fallot in most instances when the ventricular arterial connections are concordant. But all of you know that if you look at enough cases, you will come across the situation in which the narrowed subpulmonary outlet and the larger part of the aortic root are supported by the right ventricle in the setting of tetralogy. So without question, that is Tetralogy of Fallot with the ventricular arterial connection of double outlet right ventricle. And that brings us back to our spectrums, because the controversy in this setting is how we deal with the overriding valve and how do we determine whether the ventricular arterial connection is concordant or is double outlet. And in essence, what we are talking about is a series of spectrums. So this is significant for the remainder of our discussions today. What we have to do is to distinguish those individuals in which the outlets arise from separate ventricles, as opposed to the situation in which both arterial trunks in the larger part arise from the same ventricle. And what we're going to talk about very shortly is the spectrums that exist between these extremes. So the question is, how are we going to divide them? I think we agree that this is done on the 50% rule, but when we use the 50% rule, we now know that for precision, we have to do this on the basis of the short axis of the overriding arterial root rather than the long axis of the ventricular mass. So let me show you this picture that illustrates the potential problem. You see, I've shown you the situation in which the arterial root is overriding the crest of the muscular ventricular septum. And I've shown you two situations which show the variation in the long axis of the ventricular septum, AA, BB. And you all know that this axis varies within the individual cardiac cycle. And that means, and it's been emphasized on several occasions, if you take the long axis within the same cardiac cycle, at one moment, the patient might seem to have double outlet ventricle. In the next moment, it might seem to be concordant or discordant ventricular arterial connections. And that is because the long axis of the septum itself is moving during the cardiac segment. But think of the situation between the overriding arterial root and the short axis relative to the crest of the muscular ventricular septum, because that will not move during the variation in long axis of the septum itself. And I've shown you this picture before. It's an exquisite computed tomographic image made by my good friend Tony Kovarchek, Medical University of South Carolina. It is a patient who has Tetralogy of Fallot, and there, with precision now, using computed tomography, you can calculate the proportion of the arterial root that is to either side of the chord of the ventricular septum taken relative to that root. And in this particular instance, it's more or less 50-50, but we would give it to the right ventricle. So Diane now will illustrate this situation for you.
This specimen has Tetralogy of Fallot and shows us that the arterial trunks are nearly normally related in this case, with the aorta only slightly anterior and to the right of its usual position. The pulmonary trunk is quite stenotic when compared to this very large aorta. Looking within the right ventricle, we see the tricuspid valve and the significant hypertrophy of the right ventricular myocardium. Within the outlet, we see the cardinal feature, or the anterior deviation of the outlet septum. So here is our outlet septum, causing quite significant stenosis in the subpulmonary infundibular region. Also, there is a hypertrophied septoparietal trabeculation that's putting an extra squeeze on that subpulmonary stenosis. The aorta is overriding the interventricular septum, but is partly committed to the right ventricle, but in its greater part committed to the left ventricle, so that this heart with Tetralogy of Fallot has concordant ventricular arterial connections. The ventricular septal defect lies within the limbs of the septomarginal trabeculation. So here is the body of the septomarginal trabeculation with its cephalic arm and its caudal arm. The caudal arm nearly reaches the inner heart curvature and separates the tricuspid from the mitral valve along the posterior inferior aspect, but allows for fibrous continuity between the tricuspid valve and the aortic valve. Looking at the left side, here we see the left ventricular outflow tract, where we maintain some fibrous continuity between the aorta and the mitral valve. And here is our interventricular communication, and you can see the aorta partly peeking into the right ventricle, but with the greater part committed to the left ventricle. So if I tilt the ventricular mass and we look down into that aortic root, you can see the crest of the ventricular septum crossing the aortic valve, so that the greater part of this aortic valve is committed to the left ventricle and only a portion overrides and is committed to the right ventricle. This specimen shows us the arterial trunks exiting the ventricular mass side by side, with the aorta slightly anterior to the pulmonary trunk. The aorta is quite a bit larger as well when compared to the pulmonary trunk. This specimen has a ventricular arterial connection that is a double outlet from the right ventricle. When we look inside of the right ventricle, we can see the phenotypic features of Tetralogy of Fallot, with anterior deviation of the outlet septum causing subpulmonary infundibular stenosis, and some of these septoparietal trabeculations that are also hypertrophied and putting an extra squeeze on that subpulmonary outflow tract. The ventricular septal defect is an outlet defect lying within the limbs of the septomarginal trabeculation. Here is the septomarginal trabeculation with the cephalic arm rising up to join the outlet septum, and the caudal arm, which in this case reaches the inner heart curvature, so that the ventriculoinfundibular fold in this case separates the atrioventricular from the arterial valve. And this muscular bar will also protect the conduction axis during surgical repair. Within the left ventricle, we can see that the aorta and mitral valve are in fibrous continuity with one another, so that we have all of the phenotypic features of Tetralogy of Fallot, but with a double outlet ventriculo-arterial connection. If I tilt this ventricular mass so that we can look down into the aortic outlet, here's the interventricular septum with the greater part of this aortic root committed to the right ventricle and the lesser part committed to the left ventricle.
So those are our controversies. We've discussed the outdated ones. We've discussed the first of the ongoing ones. Perhaps the major controversy still persisting, however, is how best to describe the channel between the ventricles. Now, we know that the variation within all those patients having double outlet right ventricle reflects the location of that channel between the ventricles. And we can go back to the stellar paper published in by Maurice Lev in 1972. And it was at that time that Lev suggested that we could look at that defect, we could consider it to be subaortic. In a minority of cases, it could be subpulmonary, an even smaller number of cases. The defect could be doubly committed, and in another series, it could be non-committed. The majority, however, were known to have a subaortic defect. To Lev's classification, we can also add those instances in which, on occasions, the ventricular septum can be intact. This is most usually found in the setting of mitral atresia, but we have to recognize that we can have double outlet with intact ventricular septum. In this instance, there's no question but that we are dealing with double outlet because the ventricular septum is intact. And Diane will now show you an example of double outlet right ventricle with intact ventricular septum. And as she will show you, in this setting, it can be quite tricky to find the incomplete and hyperplastic morphologically left ventricle.
This specimen has double outlet from the right ventricle and shows us that the arterial trunks are normally related as they exit the ventricular mass. You can see that the ascending aorta and aortic arch are quite hypoplastic, and the pulmonary trunk and the arterial duct are widely patent. This specimen has a double outlet right ventricle, and the interventricular septum is intact. Looking within the right ventricle, it's quite dilated with prominent trabeculations and a freestanding septomarginal trabeculation. There is our pulmonary outflow tract and pulmonary valve. The aortic outlet lies just beneath the zone of apposition between the septal and anterior superior leaflets of the tricuspid valve, and we can see my probe exiting the aortic root at the base of the ventricular mass. Within the left atrium, there is a patent oval foramen with the flap valve deviated quite significantly into the left atrial chamber. At the atrial floor, there is a genesis of the mitral valve so that the mitral valve did not form, and there is a muscular floor within the left atrium. So there's no potential for an atrioventricular connection in this case. In the past, we used to take multiple sections through the posterior ventricular mass looking for a tiny left ventricle, and often this resulted in us entering the right ventricular chamber, which is the largest of the two. In this case, further exploration identified this tiny little endothelial-lined left ventricular chamber, and the ventricular septum is intact.
In most instances, nonetheless, we do have a channel between the ventricles. As I've emphasized, as Lev pointed out in his categorization, it is the location of that communication that underscores the phenotypic variability. Now, in most instances, it is an outlet defect. And it's a mistake to think that this outlet defect flits around the base of the ventricular septum. The defect is in the same place. It is the location of the arterial roots that varies relative to that defect. But it is the positioning of the defect that determines whether you have the spectrum that can be considered to represent the ventricular septal defect. If we have the same situation in which the defect is subaortic, but there is subpulmonary obstruction, we can identify the tetralogy spectrum. But then we have the spectrum where the defect is subpulmonary. And then when it is the pulmonary root that is overriding, we have the Taussig-Bing or the transposition spectrum. And then we have the additional spectrum in which both arterial trunks override the defect. And so we can call this the doubly committed spectrum. And then to complete the picture, we have to distinguish between all these spectrums of malformation and the hearts that have double outlet right ventricle with a non-committed defect. So let's now look at these variations in the overall grouping of double outlet right ventricle. And we can begin by looking at what I suggested we could call the VSD spectrum. Because the end of that spectrum in which the aortic root is predominantly arising from the left ventricle with minimal overriding is the Eisenmenger ventricular septal defect. So this is the situation where there is minimal overriding of the aortic root, but there is an unobstructed subpulmonary outflow tract. And because the aortic root is predominantly arising from the left ventricle, we have concordant ventricular arterial connections. So here is a picture that is showing you the Eisenmenger defect. I've prepared this heart by cutting away the parietal wall of the right ventricle. And I've cut away that small part of the aortic root that was looking into the right ventricle. And here you see the predominant feature of the Eisenmenger defect. And that is that the outlet septum is malaligned such that it is attached exclusively within the right ventricle. Now, you all know that this is one of the features of Tetralogy of Fallot. But in this instance, we have an unobstructed subpulmonary outflow tract despite the presence of those hypertrophied septoparietal trabeculations. And it is very possible that some of these patients who start off with Eisenmenger defects become Tetralogy of Fallot, and that is the so-called pink tetralogy. But in this instance, there has been no narrowing of the subpulmonary outlet, and these are those patients who develop very rapidly pulmonary hypertension. But what we are concerned about today is the location of the channel between the ventricles. And there you see it. It is opening to the right ventricle between the limbs of the septomarginal trabeculation. And what I have done is I've inserted the area by the green dashed lines that shows you where the surgeon would place the patch so as to put the aortic root back into the left ventricle. And this is the right ventricular margin, cone of space that is subtended beneath the overriding aortic root. And let me take you back now to development, because you have seen this picture on many instances. It's a mouse heart, embryonic day, 13.5. It's just prior to closure of the tertiary embryonic interventricular communication. And what we have emphasized again and again is that the surgeon recapitulates what the developing embryo does by turning the secondary interventricular communication into the outflow tract for the morphologically left ventricle. The surgeon does it by creating the shelf in the roof of the right ventricle, and that is what the embryo also does. And in this instance, we have a small persisting communication between the aortic root and the right ventricle. And this is the area that is called the ventricular septal defect. It is closed by the surgeon to restore continuity between the overriding root and the morphologically left ventricle. And irrespective of the degree of override of that root, it is our opinion we should continue to describe this green area as the ventricular septal defect. So what should we call the red area? That is the interventricular communication, or the defect that we're going to show you in the setting of double outlet right ventricle.
This is a specimen that we've looked at already in this session, and it shows us a ventricular arterial connection that is one of a double outlet, so that we see our aorta and pulmonary trunk arising from the ventricular mass in side-by-side fashion with the aorta to the right of the pulmonary trunk. The free wall of the right ventricle has been previously removed, and that exposes our prominent outlet septum, which is now a right ventricular structure and serves to separate our outflow tracts. Within the left ventricle, we can see the aorta and mitral valve are in fibrous continuity with one another, and that the interventricular communication is in subaortic position. The area closed by the surgeon will be effectively tunneling the aorta back into communication with the left ventricle, allowing for normal circulation to resume. So remember that the free wall of the right ventricle has been previously removed, and the surgeon will then place his patch along that portion of the anterior superior free wall, along the outlet septum and the crest of the ventricular septum, being especially careful along the posterior inferior border where there is fibrous continuity between the tricuspid and mitral valves, so that the surgeon will effectively place that patch to tunnel the aorta back into the left ventricle, and this patch, in cases with double outlet right ventricle, takes on a roughly perpendicular plane relative to the crest of the muscular ventricular septum. Now, if I use a blue glove to look at the left ventricular outflow tract, we can see where the position of that patch would be, effectively tunneling the aorta back into the left ventricle. And the position of that patch, or where the blue glove is the equivalent to the ventricular septal defect that we close in the setting of Tetralogy of Fallot. This area should also be logically called the ventricular septal defect in hearts with double outlet right ventricle.
So you've now seen an interventricular communication in the setting of double outlet right ventricle when that defect is subaortic. But what is it that determines the location of the intercommunication, the interventricular communication relative to those arterial trunks? Well, in a way, you've seen that already. And we discussed this also last week. It is the interrelationships between the building blocks of the outflow tracts. Diane has already emphasized those building blocks to you, but let me reinforce what she said. There is the defect. In this instance, it's like in the situation of the heart you've just seen, it is subaortic. There is one of the key building blocks, it is the outlet septum. I've drawn it here as a muscular outlet septum. We recognize it as the outlet septum because it separates the outflow tracts. And as you have seen, the double outlet right ventricle, it is exclusively a right ventricular structure. It inserts relative to the limbs of the septomarginal trabeculation. And what you are going to see is it is the relationship to the anterocephalad or the inferocaudal limb of the trabeculation that determines its precise location. So the septomarginal trabeculation is a trabeculation reinforcing the surface of the right ventricle. We then have another key feature to take into consideration, and that is the inner heart curvature. We call that the ventriculo-infundibular fold, and it is the myocardium that separates the hinge of the aortic valve, the arterial valve, from the hinge of the atrioventricular valve. We're going to come back to this when we discuss surgical danger areas, but for now, we want to think about the interrelationship of these building blocks relative to the channel between the ventricles. Because what you've already seen is that when we have a subaortic defect, the outlet septum is attached, and I've made a mistake here, forgive me for this. When the defect is subaortic, the outlet septum is attached to the cranial limb of the septomarginal trabeculation. In fact, it is attachment of the outlet septum to the caudal limb, which means that the defect will be subpulmonary, and that is what we call the Taussig-Bing spectrum. So now we're going to look at examples of the Taussig-Bing spectrum with one caveat. The heart that Diane is going to show you that has discordant ventricular arterial connections is a rare example in that the defect is beneath the right-sided pulmonary trunk, because in the heart she's going to show you it is transposition SDL. The aorta is anterior and left-sided. But she's going to make the point that the channel that is closed by the surgeon is the ventricular septal defect, and it is the communication between the right ventricle and the overriding arterial root.
This specimen has a ventricular arterial connection that is one of a double outlet, with the aorta arising anterior and rightward of the pulmonary trunk. This specimen also has usual atrial arrangement and right-hand ventricular topology. If I tilt the ventricular mass upwards, here we can see that the subaortic outflow tract is composed of a complete muscular infundibulum supporting the aortic valve as it arises from the right ventricle. And here is our outlet septum that is a prominent right ventricular structure and separating our outflow tracts. The pulmonary valve is clearly looking in its majority into the right ventricle, and we can see that the interventricular communication is in subpulmonary position. The pulmonary valve and mitral valve are in fibrous continuity with one another within the left ventricle, so that when the surgeon places the patch, it will effectively tunnel the pulmonary trunk into the left ventricle and become the new outflow tract for the left ventricle. So the patch will be sewn along this anterior superior aspect of the outlet septum, along this parietal wall, along the crest of the interventricular septum, and with great care along the posterior inferior aspect. And I say with great care because the tricuspid and the mitral valves are in fibrous continuity along the posterior inferior border, so that this is a perimembranous defect, so that the interventricular communication will be effectively closed with a patch in this area, and you'll see that it is nearly perpendicular with the ventricular septum to effectively tunnel the pulmonary valve back into the left ventricle. Once that is completed, the surgeon will then have to do an arterial switch to correct the circulations. This specimen has had the majority of the free wall of the right atrium and right ventricle removed, along with a portion of the ascending aorta. The specimen has the aorta arising from the right ventricle, or discordant ventricular arterial connections, and it arises anterior and leftward of the pulmonary trunk. It's important to note that this specimen has usual atrial arrangement and as well right-hand ventricular topology. There is a ventricular septal defect that is an outlet defect as it extends between the limbs of the septomarginal trabeculation. It is also a muscular defect as the borders are entirely muscular. The caudal arm of the septomarginal trabeculation extends to reach the inner heart curvature. If I tilt the specimen upwards, you can see that the pulmonary valve is slightly overriding the interventricular septum, but it's supported in its greater part within the left ventricle. It just overrides slightly. When the surgeon is going to repair this defect, they do it from the right ventricle and will place sutures around the muscular borders, effectively closing the ventricular septal defect so that there will be no potential for shunting at this level. This ventricular septal defect, closed by the surgeon, is analogous to the defect shown in the previous heart with double outlet right ventricle. In both instances, the surgeon will then have to do an arterial switch to completely fix the circulation.
So what we've looked at now is we've looked at the spectrums in which it is the aortic root that is overriding. We've looked at the spectrum in which the pulmonary root is overriding. But we have another spectrum to consider, and that is the situation that we describe as the doubly committed defect. Now here, our thinking has moved on as we have seen more specimens, because we used to think that whenever the outlet septum was fibrous, then always we would have a doubly committed defect. We know now that is not the case, and I can illustrate that to you in this beautiful picture. It's another of the pictures taken by Diane. We don't have this heart to show you, so I'm having to illustrate this with still images. But you'll appreciate we're looking at the base of the right ventricle in a heart that has double outlet ventricle. And what I hope you will see is that separating the aortic root and the pulmonary root, we have an outlet septum. It is exclusively a right ventricular structure, but rather than being muscular, it is fibrous. So the defect itself remains opening between the limbs of the septomarginal trabeculation. And the fact that the outlet septum is attached to the anterocephalad limb of the septomarginal trabeculation means that in this instance it is narrowing the subpulmonary outlet. So there is the interventricular communication. Unequivocally, in this instance, it is subaortic, despite the fact that we have a fibrous outlet septum. So we should not be calling this a doubly committed defect just because the outlet septum is fibrous. It is, however, the case that in most instances when we have a doubly committed defect, the outlet septum is fibrous. So in this particular heart, you see there the pulmonary trunk, behind it, you see the subaortic outflow tract, and again, they are separated by a fibrous outlet septum. But this time, the outlet septum is floating. It is attached neither to the cranial nor to the caudal limb of the septomarginal trabeculation. And it is the fact that it lacks those connections that both arterial trunks are now able to float above the interventricular communication. The interventricular communication, again, is opening between the limbs of the septomarginal trabeculation, but because the fibrous outlet septum is floating, the defect is not only subaortic, it is also subpulmonary. Another key point here is to look at the caudal limb of the septomarginal trabeculation, because as you see in this particular heart, it is fusing with the inner heart curvature, and that fusion of the caudal limb with the inner heart curvature protects the atrioventricular conduction axis, meaning that this is a muscular outlet defect that is doubly committed. So it is a neutral position of the outlet septum that produces that doubly committed variant. And as we have discussed previously, that spectrum of shift from the right to the left ventricle means that these hearts oftentimes can be described as showing double outlet both ventricles. But what we also know now is that the doubly committed variant can be found with a muscular as well as a fibrous outlet septum. So this is one of the lovely hearts prepared by Vera Aiello, who, as you know, is the cardiac pathologist who works at INCOR in Sao Paulo. And Vera works very closely with us, and this is from the paper she wrote on the building blocks of the outflow tracts. So there you see the pulmonary root. The aortic root is right-sided, and there separating them is an outlet septum which has no direct connection to the limbs of the septomarginal trabeculation, so again is free-floating. There is the interventricular communication, and you see that it is opening between both the pulmonary root and the aortic root. It is doubly committed. You'll also note the caudal limb of the septomarginal trabeculation has fused again with the inner heart curvature, meaning that this is a muscular outlet defect, but now one that is doubly committed. So that is our third spectrum. We have the spectrum with overriding aorta, the spectrum with overriding pulmonary trunk, the spectrum with overriding of both arterial trunks. So what about the non-committed variant? Well, in rare instances, it can be produced by a muscular defect that is either opening to the inlet or to the right ventricular apex. And here is one of the first hearts I ever saw of double outlet right ventricle with a non-committed defect. There is the aorta, there is the pulmonary trunk. There had initially been an outlet defect, but it had closed spontaneously. So now the only communication between the ventricles is a muscular inlet ventricular septal defect. And no question but that this defect is non-committed, because as you see, tricuspid valve is positioned between the defect and both outflow tracts. But more usually, when we find the non-committed variant, the defect is part of an atrioventricular septal defect, or else it is part of a perimembranous defect that opens not only to the outlet, but extends so as to open to the inlet of the right ventricle. And then it's often the case that the surgeon would be able to create a tunnel so as to connect the interventricular communication to one or other of the outflow tracts. And it is this feature that gives problems on occasion in determining whether the defect is committed, whether it is subaortic, so that the surgeon can simply patch the aorta into the left ventricle, whether it's subpulmonary, the surgeon would then be able to patch the pulmonary trunk into the left ventricle and then do an arterial switch procedure, or whether it is sufficiently far away that it is considered to be non-committed. So now we're going to look at another heart which has this situation, and Diane is going to discuss with you the potential problems of commitment or non-commitment of the interventricular communication.
This specimen has had the anterior free wall of the right atrium and right ventricle previously removed, along with the anterior portions of the arterial trunks. This specimen had a common atrium with a common atrioventricular junction and a common atrioventricular valve. The ventriculo-arterial connection was one of a double outlet with the aorta supported in its greater part above the right ventricle. Also, we see the phenotypic features of Tetralogy of Fallot with this elongated outlet septum deviated in anterior superior direction to cause subpulmonary infundibular stenosis. The crest of the ventricular septum is scooped out, as is typical in cases with a common atrioventricular junction, and we can see the inferior bridging leaflet, which is tethered to the crest of the muscular ventricular septum, and a free-floating anterior superior leaflet. The surgeon, when patching this defect, will first repair the ventricular component of the atrioventricular septal defect and fashion a teardrop extension from that patch to effectively tunnel the aorta back into communication with the left ventricle. So if I reoppose the free wall and the outlet septum, you can now see where the aortic outflow tract would be, and that patch would be sewn along this anterior superior aspect of the aorta as it exits the right ventricle, and that teardrop patch fashioned in such a way that it would tunnel the aorta back into communication with the left ventricle, effectively restoring the circulation.
So let me emphasize what we've now seen about the interventricular communication, because although it can be subaortic, subpulmonary, doubly committed, non-committed, we also need to know of its own phenotype. And the feature that makes the defect perimembranous is fibrous continuity posterior-inferiorly between the leaflets of the mitral and tricuspid valves. And that is key, because then the conduction axis will be at risk posterior-inferiorly. You've already seen, however, that in many instances, caudal limb of the septomarginal trabeculation confuse with the ventricular infundibular fold, and that produces the muscular posterior-inferior rim that protects the conduction axis. So this brings us back to those building blocks of the outflow tracts. And it is recognition of these building blocks that identifies for the surgeon the danger areas. So let me remind you again that our illustration is showing you a subaortic defect. And there we see the outlet septum. Now, the outlet septum is always safe, because never does the outlet septum contain the conduction system. So it can be resected, providing that care is taken to avoid the hinges of the leaflets of the arterial valve, which self-evidently are on either side of the outlet septum. And remember that on occasion, the outlet septum is fibrous rather than being muscular. Here we have the septomarginal trabeculation. Let me remind you, that is the strap that is reinforcing the septal surface of the right ventricle. And the body of the septomarginal trabeculation is safe. The anterior limb is relatively safe, cranial limb, although behind that you will find the septal perforator. On occasion, it may be necessary to resect this anterocranial limb so as to enlarge the interventricular communication. But there is a danger area with the septomarginal trabeculation, and that is the posterocaudal limb, because at the inferior end of that limb of the septomarginal trabeculation, we find the atrioventricular conduction axis. So the major danger area will be when there is arterial to tricuspid continuity, or when there is mitral to tricuspid continuity, because that makes the defect perimembranous. And then, as you know, in that setting, always the conduction axis is at potential risk. So when there is fusion of the caudal limb, the septomarginal trabeculation with the inner heart curvature, the ventricular infundibular fold, that myocardial bar will protect the conduction axis. And then the final building block is the ventricular infundibular fold itself. It is safe as far as you are concerned with conduction tissue. It is possible on occasion even to resect the ventricular infundibular fold. But remember, if the surgeon resects the ventricular infundibular fold, he or she goes outside the heart. Lurking on the epicardial aspect potentially will be a coronary artery. The surgeon is aware of those problems. Then, providing it's all sewn up again, it can be resected, but there are those danger areas. So, a word about arterial relationships. We have not had time to illustrate this for you. Typically, the arterial relationships are spiraling or normal when we have a defect in subaortic and doubly committed position. When we have side-by-side relationships, you can't, on the basis of that, determine the location of the defect, but certainly it is more likely to be subpulmonary in the setting of side-by-side defects. The aorta, however, can also be anterior when the defect is subpulmonary, but please do not describe that as transposition. There is that additional feature in which the aorta, with usual atrial arrangement, concordant atrioventricular connections, the aorta is left-sided rather than right-sided. And indeed, we've seen an example of that in the setting of discordant ventricular arterial connections, and in that setting, the defect happened to be subpulmonary. More usually, when you have double outlet right ventricle with left-sided aorta, the defect is subaortic, and then the surgeon is able to patch that left-sided aortic root directly into the morphologically left ventricle. We have not had time to show you all these variations, but you must take them into account. So what we've tried to emphasize over the past 2 weeks is that double outlet ventricle is not a phenotype. It is a group of lesions with their own phenotypes that we put together because they have the same ventriculo-arterial connection. Our take-home message is that it is the channel between the ventricles that is the most important morphologic feature, and it is the right ventricular margin of the cone of space beneath the arterial trunk closely related to the defect that we believe is the ventricular septal defect. So the channel that you typically see in the setting of double outlet right ventricle, in our view, is better described as the interventricular communication. But do not forget to look for all those other associated lesions, because anything that can exist at some point of time will coexist with double outlet right ventricle.
Very good presentation, Dr. Anderson. Thank you very much. And I think we had a very good month on your sessions. And I think the what Dr. Diane showed us as well complemented very well. And we are very happy to see one image of what Dr. Vera Yellow showed. She is inspiration to all of us Brazilians, and I feel very blessed to have been trained by her, to have her during my fellowship, and nowadays to have her as a friend. So thank you for showing us that. To starting with, I usual to ask Dr. Silverman to give his thoughts about what was presented.
Really, I think that there's very little to say because it was very clear. There was nothing except for the arterial relationships that we didn't discuss, but I think that's easy. I think the most important thing for me today was to consider the building blocks as separate entities and to identify them all. And I think that that diagram that Bob showed with the consecutive development of where the ventricular infundibular fold lies, where the subaortic infundibulum lies, the conducting axis, the outlet septum was just so clear. And I think that how I will change my practice is that when I identify a patient with double outlet, I will look for all of these building blocks in my head to see that I can show them and describe them to the surgeon in such a way so that when he does a repair, he can consider how we have described the defect to him in detail. And the only other comment that I have is related to one of Diane's specimens, which was the last specimen, I think, with the AV septal defect and the outlet septum. So I think that that was interesting because previously I've seen that specimen in its fresh state. Diane has given me that image. And I think you could describe that as a tetralogy of Fallot with an AV septal defect and double outlet right ventricle. And I think that that was another illumination to me because previously I've looked at that merely as a tetralogy without considering the commitment of the defect in its outlet stage to being a double outlet right ventricle. That's really all I have to say. It was marvelous. And the only thing that I'm sorry about is that there isn't a third session where we repeat all of these things again so that we can understand them. But then I think that for the Congenital Heart Academy, one has to say that the YouTube channel has all of these things on it. And I think that when you look at that, you will understand that the depth of these discussions is such that a repetition will only improve your understanding. That's all. Thank you.
Well,
Thanks,
thank you,
Diane.
Norman.
Thank you, Bob.
Thank you, Norman, for those comments. And you make an excellent point. Grace, do you happen to know whether Adrian is with us today? I know he's been very busy and he was threatening to be present, but he told me he had many other things that were occupying him in Birmingham. But Adrian has commented and he's made the point to me that there are so many things about double outlet right ventricle that remain controversial. And like you, Norman, Adrian commented that he would have liked a third session. And I can see the point that you made because we didn't have the time today to discuss arterial relationships. It would be very useful, I think, to go over again the controversies. I hope we've resolved those controversies. But I note also that one of the questions we've been asked is, why can't we talk about double outlet right ventricle with transposition? And I hoped we'd explain that because transposition nowadays is recognized as a discordant ventricular arterial connection. Double outlet is a different ventricular arterial connection. So you can have double outlet right ventricle with anterior aorta, but that is no longer double outlet right ventricle with transposition. So these are the things that, as Norman points out, we need to say over and over and over again. And I don't think we can. We just don't have the time to do it all that many times. So Grace, is Adrian with us today? Do you happen to know?
No, unfortunately, he was not able to join today. So I think it's another reason for the third session. Maybe next semester we can think about it.
You make a very good point there, because we're contemplating what we're going to do when we start again in the next year. And Diane made the point when she and I were discussing what we would do in the remaining sessions until the end of June. And Diane makes the point that so many things depend on normal anatomy, and she has so many beautiful presentations on normal anatomy. I think yesterday, Diane, you presented to your fellows and your colleagues at St. Petersburg your presentation on normal anatomy. Perhaps you'd like to say a few words about that. You're muted at the moment.
Yeah, I did do a presentation for our Thursday morning educational series, and I think it was well accepted. I had a few texts that gave me some good feedback, and I just think it helps people to know some of that intricate anatomy that we don't always focus on. And secondary to being involved with you and some of the MRI comparative studies,
You're a busy girl.
That has made a difference in the way I look at the normal heart, and it has really helped me to bring home some of these spectrums of defects that we look at. So I think it's important for people to know that intricate anatomy and how things are interrelated.
So when you gave the presentation yesterday, did you do it using video presentations?
I did it with a document camera and the actual heart specimens themselves. So many of the dissections that have come out of some of the things that we've been involved in the past few years.
And presumably you were able to record the entire session.
I think it was recorded, but I didn't do it myself.
Right, but when we start our sessions next year, you'll be able to put some of those clips that you've made, and we'll be able to use those to demonstrate the significant features of normal anatomy.
Yes, because as you know, we've already done a number of those normal clips for these sessions, and they can just be added to.
Hi, this is Jim Q. I will tell you that the presentation that Diane made was exquisite, and the detail and the things
We
that
don't see you, Q. Show us your.
I tried, I couldn't do it. I'm locked out of the video for some reason.
Well, we're pleased to hear from you.
But at any rate, it was a beautiful presentation. The detail was exquisite, and I think you continue to learn every time you kind of look at it at that in-depth level. And no, it was really, really well done. So very good.
Well, thank you for those comments. And for myself, I have to say that the way that we've been able to patch the clips that Diane has made into the narration that I've been doing over the past few weeks has been quite spectacular. Yeah. And I'm hoping we can expand upon this when we start again at the beginning of next year. But Alan, do you have any comments on what you've heard and seen today?
A couple of things. Very beautiful presentation as ever. Your stepwise presentation of the building blocks and the danger areas made me quite glad I'm not a surgeon. There's so many danger areas to look at. I think one of the things in pediatric cardiology is we tend to take shortcuts when we're describing things to other people. For example, people use the term double right ventricle with transposition. Is it acceptable to say with transposition physiology, for example?
Oh, no. Indeed. Yes, absolutely. I'd be very happy with that, because in essence, that is the Taussig-Bing spectrum.
And essentially, in many ways, the Lev classification is still acceptable, isn't it?
Indeed, yes.
Absolutely. I think the only other thought is the difficulty sometimes with these so-called remote VSDs or non-committed VSDs, what to do with them. I spent a day once in Cairo sorting out patients with transposition, but they weren't transposition. There were all sorts of things to decide which ones were operable, and it was a real nightmare because they were all different, and it was really quite an interesting day. So
I'm sure
60 patients in one day. And
I'm sure they also showed you the Sphinx, so it was not all bad.
Well, I always remember that as Norman Shumway used to say, eventually all bleeding stops. And I think we can expand that to say that there is no heart that somebody cannot operate on. And there's always something that they can do to fix it. But Bob, if you don't mind, if I can share my screen with you for a moment. And let me just share you this picture. Now, Bob will say that I have stolen all of his pictures. So let me actually say that first. But here essentially is some of the problem that we have with the double outlet transposition spectrum. Because in 1982, Bob, this specimen was labeled by you as transposition. And I think that we have come to look at this specimen and say it's classical for double outlet right ventricle with a subpulmonary ventricular septal defect. And I think that from your lecture today, I think you could say that we can identify the building blocks, and the building blocks are all those of double outlet right ventricle. Would you agree?
Oh, you're 100% correct. And I mean, it's significant that you have that picture, because I don't have that picture anymore, and it's a beautiful picture.
I'll send it to you, Bob. I have several copies of it.
The problem that we have, as you know well, is that we cannot judge the extent of override of that pulmonary trunk by looking at the long axis of the ventricular septum. And you were skewered on this, as you will remember, in your debate with Taussig-Bing. And now, as you and I know, we should be looking at the short axis. And I am sure you are correct that if we put all of this together and we looked at the short axis of the chord of the ventricular septum in this heart, we would see that the larger part of the pulmonary trunk, along with the aorta, was arising from the right ventricle. Now, there's another point to make here, because one of the questions we've been asked is, can we say that the interventricular communication is usually related to the larger of the arterial trunks? And I think that as a general rule, that is the case. And I think that what you are showing here in this exquisite picture is that the aortic root is narrowed. You can see that it's a squeeze between the outlet septum, the parietal wall of the right ventricle, the ventricular infundibular fold, and the interventricular communication is committed to the pulmonary trunk. So I think as a general rule, that is the case. But as in all instances, it's the exceptions that test the rule. But the point you made earlier in today's discussion is the key one. You should be identifying the building blocks, put them all together, describe what you see, and there you have the answer to the problem.
Sure. By the way, you do have this picture because it's in our app, and you've seen it, but I will send it to you separately. And of course, if there's any other picture that you need from your archives that you don't have, I have them.
You have a much better coding system than I do. I've lost a lot of mine.
Oh, dear. Well, anyway, I could send this to you for sure. But thank you once again. And I think that, I mean, looking at all of these things, and perhaps for us to go back and look at the 3 sessions, the 2 sessions on double outlet, and there have been others, I think, previously, and to look at them and try and crystallize out what we need to maybe augment in discussion would be a great idea for another session.
Indeed.
This is Jim again. I wanted to just see if I can make a comment just regarding the surgical, some of the surgical aspects that we've mentioned and touched on. Just as a general rule, there's 4 things that I think are really important for the surgeon to understand when you think about reconstructing a heart with double outlet ventricle. And that's the position of the AV valve, the ventricular septal defect, and the outlets that need to be reconstructed. And I think if we just kind of imagine a tunnelization of the VSD to the outlet that you want to do, if it's a regular double outlet versus a Taussig-Bing, one being the aorta versus the pulmonary artery, how long that distance is and how narrow it might be because of the AV valves kind of encroaching on that pathway. That's kind of the concept that I think is important for our imagers and our surgeons to be thinking about as we approach the reconstruction. it's those four elements and the pathway and the position of the VSD.
I think that's like, Alan, yes.
No, just that's very nicely put. That crystallizes the whole thing. That's very nicely put.
The only thing I would add is that what Jim is calling the VSD is in fact the interventricular communication.
Yes, that's correct.
Apart from that, it was
That's too many words.
And it's where, I mean, the key point that you make, it's the sutures that you place to put the tunnel in the appropriate position. Those sutures are demarcating the plane of what is the embryonic ventricular septal defect, and that is what you have to close. But I think, as Alan says, the account you gave is perfect, and that's what we need to know. And certainly the point you make about the atrioventricular valves is key. And I think Diane also showed that in that lovely specimen of the heart that has an atrioventricular septal defect coexisting with the subaortic defect, because there, first of all, you have to close the ventricular component of the atrioventricular septal defect, and then you would have a very long tunnel so as to put the remaining interventricular communication into the aortic root. On occasion, it might be easier to put it into the pulmonary trunk, but then you'd have to do an arterial switch procedure. Grace, you're in charge.
Yeah, we have a lot of interesting questions. So the first one you already answered about with transposition. So there's another question talking about, is there any relation between Gazoo phenomenon and Eisenmenger type of Dorf? I have no idea what Gazoo phenomenon is.
Well, that's a pity, because I hoped you were going to resolve that for me, because I don't know what the Gazoo phenomenon is either. Norman, can you help us? Or
I don't. I'll Google it for you. I think it's a subpulmonary obstruction that develops in the ventricular septal defect. But I'll Google it for you now, and while the stuff is on, I will get back to you with an answer.
Okay, it's an anonymous attendee, so if you who made this question could clarify for us, I'm sure the panelists will be happy to answer your question. So there's a question from Guadalajara in Mexico. Thank you for attending. And so Juan Rafael is saying the insertion of the outlet septum in the limbs of the septomarginal circulation, anterior or posterior, permits one to determine the infundibular relationship.
Rather, I would say it permits you to determine whether the interventricular communication is beneath the pulmonary trunk or the aorta, with the one proviso that on occasion, for example, if you have a left-sided aorta, the aortic root is where you expect the pulmonary root to be. So again, we can give general rules, and we can say that when the outlet septum is attached to the cranial limb of the septomarginal trabeculation, the defect will be subaortic. When it's attached to the caudal limb of the septomarginal trabeculation, the defect will be subpulmonary. When it has a neutral position, there will be it will be doubly committed. But the problem, the hooker, all the time, we have the exceptions that test the rule.
Okay, very nice. There's one question about the coronary anatomy, if there's any prediction of any variation.
I think the point about the coronary anatomy is if you have a subaortic defect, then the coronary arteries essentially are going to be as you would expect in the Tetralogy of Fallot. If you have the Taussig-Bing variant, then anything that you find in the setting of transposition, you can find in that variant of double outlet right ventricle. So there you'd have to use the Leiden convention. With the doubly committed variant, I think that is closer to the tetralogy variant, to the transposition variant. But again, I would describe it as best I could using the Leiden convention.
Okay. And Alejandro is asking, is it still be valid when we do echo to assume that the largest arterial root is frequently the one that has a relation to the VSD?
The interventricular communication.
Yeah.
Norman, is that your rule? I've already answered that from my stance.
I'm sorry, Bob, I was busy searching a Gazoo phenomenon, so I wasn't paying attention.
So The point we made when we were discussing that heart that you showed on your, do you think that it's the rule that the interventricular communication opens beneath the larger arterial root? And is that an echocardiographic clue?
Yeah, I think so. I mean, I think in general it's the case. I think there might be specific cases where that's not the case, but right now I can't think of anything. I think that is a pretty reasonable rule. And also where the outlet septum is situated. I think an outlet septum that is really deviated, as it was in the case of the example that I showed you, towards the free wall of the right ventricle, causing subpulmonary narrowing, is another good example of the swinging of that outlet septum, which brings the other great vessel right in line with that.
Alan, do you have any comments on that from your echo experience?
Gosh. Not really. I mean, people are talking more and more about different imaging modalities to look at this. I think that you can be misled on the echo sometimes if you're not careful, but.
Would you use CT these days to look at double outlet right ventricle?
Well, it's one of these things that people talk about, you know, CT or MRI, and then doing reconstructions and making models and so forth. I guess it depends on the individual surgeons, what they feel comfortable with in terms of imaging. It's not acceptable anymore to have this, you know, just allowing the surgeon to decide the table, because I think people need some warning. But we have had trouble before with echo in deciding exactly what was going on, for sure.
I mean, to me, the images you can get with CT now are truly spectacular, and you can do it with very low radiation dosage. I know there was the worry about radiation dosage, but I think the detail you can now get with CT, it takes, as you know, it only takes milliseconds now.
Yeah,
and the information I was asked about the coronary arteries. If you did CT, you'd know precisely the relationship of the coronary arteries.
Sure. So I'm going to share my screen again with you, Bob. This is maybe a little bit surprising for you. Let me see if I can get it up. Yes, here we go. Here's a picture of the Gazul phenomenon, and it was described in 1957 by Dr. Gazul as an intriguing phenomenon of secondary infundibular stenosis in ventricular septal defect. So that's what the Gazul phenomenon is. And Bob, I think you were still editor of the journal at this stage. I especially took cardiology in the young, which is a very nice example. And they even have, it's from India, I assume.
It is from Mumbai.
They have beautiful pictures of the secondary phenomenon here related to the development of the tricuspid tissue tags, causing this is a short axis. I can't see my arrow very clearly, but their big white arrow shows the tricuspid tissue tags encroaching on the right ventricular free wall, and next to it is the color compare image showing the narrowing that occurs as a result of this. I always thought that this phenomenon was infundibular, but I guess, and certainly the way Gazul described it was the case, but that's what we have to answer the questions of the panelists. And
well, I can plead the Fifth Amendment here, Noam, because this had nothing to do with me. I had given up by 2016.
All right, well, that's great that this is 2015.
Yes.
2016, yeah.
Yes, but it is a very beautiful image as you show there. And in fact, yeah, the same thing, the Gazul phenomenon, if I understand you correctly, would also reflect the change from the Eisenmenger defect into the tetralogy.
That is, well, I think clinically, what happens in this phenomenon is you have almost like what they used to call a double-chambered right ventricle, the same physiology that really occurs is that as the ventricular or the muscle bars become more hypertrophic, the outflow tract becomes more stenotic, and you move from a pink patient to a blue patient. So I think physiologically we understand it, and I think this is a nice description of a Gazul phenomenon, but really the phenomenon that was described by Gazul was one of infundibular stenosis that was related to muscular hypertrophy.
And we should also explain that Gazul himself was the pediatric cardiologist who worked at the University of Chicago.
Yes.
He was a major figure in North American pediatric cardiology, and in fact, he worked with Maurice Lev, and they produced a wonderful textbook, which is called Gazul, Arcilla, and Lev. And René Arcilla, the third of the triumvirate, was a superb physician who set up the center at Advocate. And I know René well, and he is quite superb.
Yeah. So if we were to go back to that picture that I put up from your archive, Bob, that you no longer have, the sort of Gazul phenomenon that occurs in the double outlet with a subpulmonary VSD, subpulmonary interventricular communication.
Thank you for that.
Sorry, gets worse with time because of the fact that there's hypertrophy that occurs there, and as the hypertrophy progresses, the outlet will get smaller and smaller, just as you see here in the angiographic example. That's so beautifully. So anyway, I hope that's answered that question.
Well done. That's a great answer. Grace, back to you.
Thank you. My connection is horrible, but I'm managing. So we have a question from the Carlos Troconis, who is always with us. He's saying that, so calling Fallot variation or physiology on the presence of Dorf connection or transposition variation physiology is not longer used, should be used. Spectrum is the word. So back to that discussion that you have, how to say this.
I mean, Norman, what do you think about that? Or Alan? I'm very comfortable with talking about the spectrums, and I'm very happy with the tetralogy spectrum, the transposition spectrum. Alan, you?
Yeah, absolutely. Yes, absolutely. But
I think that's probably the best way to think about it, because in embryology, there's no taxonomy like this. It's just how the thing develops. And I think that we've got on the two ends of the spectrum, a tetralogy of Fallot on the one side, and on the other one, transposition of the great arteries. And there's a spectrum of best things, as you can see from the specimen that we showed, an area where it becomes arbitrary, in fact.
And in between, you have the double outlet both ventricles.
Yep.
That's right. So I've always thought of it along those lines, but I think that the building blocks issue, I mean, the question how you can solve the issue so clearly with a cartoon is really quite amazing to me. And it really, I mean, the people that draw the cartoon shows the understanding, and I know that's your understanding, and I think Gemma Price, who's the artist that did that, is really happened to perceive so beautifully all of the questions that you described to her, that she could actually assemble such a marvelous cartoon.
Well, as you also know, Norman, for a long time we depended upon Professor Ho to provide our cartoons, and she was also excellent.
She's outstanding.
Translating what we were trying to do and put it into pictures.
Yeah.
And
Dr. Ho is a great artist.
You've stolen all her pictures as well.
Everybody's, Bob, everybody's. But let me point out to you now that there's no problem about stealing pictures anymore, because they're all on the Congenital Heart Academy. If you want to see any of the pictures that Bob or I have shown you, or anybody else, just go to the Congenital Heart Academy website and pull them up.
Nothing is sacred anymore.
That's right.
Guys, can you still hear me? Because you are breaking for me. Is that okay? Okay, very good. So we have one question saying, so it can be safely said that the tetralogy of Fallot is midway in the spectrum of double outlet ventricle, usually right. One end being Eisenmenger VSD, the other being Taussig-Bing variant. Normally committed great arteries versus discordant great arteries. Still the same discussion. What do you think?
Indeed, yes.
Okay, Carlos made a question, maybe a suggestion to Diane. So he said, can some of your specimens be 3D printed to have a model in hard or soft plastic?
I'm not sure that we would be able to do that. I know when Bob and I were in Chicago at Lurie Children's Hospital, we tried to sew back together a normal heart that was cut in a 4-chamber plane and get the septums and everything to stand up the way they would have been when the heart was having its normal circulation. And it came out okay on the imaging, but some of the septums and alignments were collapsed, and I'm not sure that it would work very well. I think it would be worth trying in some hearts that were fixed by perfusion fixation and then sectioned. I know I have a couple of hearts from the Van Meerup archive at the University of Florida that would probably work very nicely for this, but not all of the specimens would be amendable to 3D printing just because they're floppy and they can't be restored to their normal positioning.
And it's also questionable now with what you can get with 3D data sets in clinical situations. Why, if you're going to print anything, why would you want to print a specimen when you can print the heart itself?
Oh.
Right.
While there's a moment of silence, I'd like to share my screen again with you. Bob, you've taught me something, that if you really want to look at anything, you can just go into Google. And so here is the paper by Vera Aiello with all of the diagrams. And you notice that Professor Anderson is also an author on this paper. But it really contains the most spectacular series of comparisons that I would direct the viewers to look at.
And Diane is there also.
Oh, there she is, right there. I missed you, Di.
Oh, that is very nice.
Prominent author. But I mean, you know, for those of you that are having problems, look at this, or you can even go and get the app that I've made on Double Outlet, which contains all of Bob Anderson and Diane Spicer's images as well.
Very nice. Dr. Diane, there's another question for you. And it was asked if what was the topography of the coronary anatomy in the hypoplastic LV that you showed?
I am not sure what that coronary anatomy was. I really can't comment on that. I don't remember, honestly.
Okay.
Sorry.
I could make a little comment about looking at coronary arteries from ultrasound. And I think that it's a very useful to be able to see the origins of the coronary arteries in double outlets. And my experience is that in the subaortic variety, the coronary arteries are most frequently usual in their arrangement. But in double outlet, where there is a subpulmonary interventricular communication, because of the position of the great vessels, the sinus number 2, I think, runs posterior to the great vessels, and there's either a circumflex or a single origin of that coronary in a much higher frequency. And so I think that you need to look at that very carefully as an ultrasonographer, is to look in short axis again, as Bob had mentioned, and you see the position of the vessels, identify the particular sinuses, which is adjacent and non-adjacent, and then trace the coronary arteries. And when the coronary artery is running posterior to the great vessel roots, that is always a risk for having a circumflex or a single left, or in rare cases, the so-called double loop pattern of coronary anatomy.
Okay, very nice. Jason is.
Grace, I notice we have a series of comments by Jagannath, who is one of our regular attendees, and Jagannath is excellent. So it's very encouraging to see that the final comment from Jagannath is that a lot of misunderstanding has been cleared up. So that is very encouraging to me.
And the session was very, very good. The last 4 sessions were really amazing. TJ and North, I really learned a lot as well. So I'm sure it clarified a lot of things to everybody. Do you want me to read his comments to everybody, Dr. Anderson?
I think they can read them themselves if they go to the question. I think the question and answer box is available to everybody, is it not?
Yes, it is. Yes. So we have one more question. Jason 10 is saying, is it possible that the outlet septum, instead of lying between the outflow tracts, align horizontally below one of the outflow tract itself?
That is certainly possible, but it would still be between the outflow tracts. It has to be between the outflow tracts, else otherwise it is not an outlet septum. So I think that the orientation of the outlet septum can then vary between it being horizontal or between it being vertical, but it has to be between the outlet tracts so as to qualify as the outlet septum. I mean, Norman, do you want to make a comment on that? You look a bit...
No, I think not. I think you've done just a great job, Bob.
Okay, I think we still have some questions, but we've been a long time on this one. I think we can choose one or more, one or two, Dr. Anderson, and just close up. There's one, it's not really about the topic, but is a sonographer obstetric that is asking something. So maybe Dr. Silverman is going to be useful for him to answer that. He's saying about pulmonary arteries length. Do we need to scrutinize where is left the pulmonary artery? He's an obstetric sonographer, and is it 3 VTV enough?
Well, I don't know who is the author of that question, so I can look at it.
It's Johan with Jaija. While you do that, there's a question.
Johan Wider.
Yeah.
Okay, about pulmonary artery sling.
Yes.
Yeah. Well, I think it's pulmonary artery sling. I think is a very rare phenomenon, but it can occur in all sorts of circumstances, and I think you have to be able to look at that. I've never seen this anomaly in double outlet right ventricle, but I've seen it with tetralogy, and of course this is all part of the second heart field problems that can develop. I think you just have to look at the branch pulmonary arteries, obviously, as an echocardiographer. And when you don't find a left pulmonary artery origin, you have to go and look for where it can come from. And that is either attacked by looking at a suprasternal notch images or a high parasternal short axis image to look for the sling under normal circumstance. And I can't believe that it will be any different in double outlet right ventricle.
Norman, you'll be pleased to know there's a question here, the final one. Could you please tell them about your app for DORV?
This is an app which Bob and Diane and I have put together, where we discuss echomorphological correlations. It's published on the site. Maybe Grace will put it on for us, www.md1world, that's one is the number one world, www.md1world.com, and the book is available chapter by chapter. You can select what you want to buy. It's $8 for the chapter, and it contains all of the moving echocardiographic images and the still frame images of pathology as a comparison as we go through the spectrum of diseases in either direction. So once again, www.md1world.com. You can look at it. You don't have to buy it, but you can't download it. And the beauty of this, it can be downloaded onto your phone, your tablet, or your computer. And once you have it, it is always yours. There will be no second edition because this can be updated. And as we find new updates and new information, we'll just place this on the app and you will get to see the latest app as you upload it.
I think I wrote it wrong. It's www.md1world.com. Is this correct?
World, W-O-R-L-D, world, yeah.
Or, yeah, it's not coming. Okay, maybe it's my internet that is horrible here.
Yeah, I'll pick it up for you in a second and show you. If you give me one second, I'll have it up for you. And
I just need to say that I bought all the chapters and they are awesome.
Thank you very much. Let me just get one chapter up for you.
Okay, on this meanwhile, we have one more question. It's about if we can use the coronary artery topography to guide where the ventricular septum is.
Absolutely. If you can find the inferior interventricular and the anterior interventricular artery, they are the best guide from the outside of the heart to the location of the ventricular septum.
Okay, very good. And let's see what else we have. We have a lot of people saying thank you because it's a really good session. And I think that's what we have for now, guys. It was very good.
Just hold on 1 second.
Yes, sure.
Okay, and now I'll try and share my screen again. And here it is. So here's what the book looks like. And
that's the link, Dr. Silverman.
Pardon?
It's really www.md1world.com. Yes. It's not .org or anything.
Oh, well, I don't have it up on this chapter, unfortunately. And I thought I would just show you how the comparison runs, and you'll recognize all the pictures that we have. And here is the first example of what we were looking at with double outlet by parasternal long axis image. So, and there's a text which describes the figures, and the figures move. So everything goes away, as you can see here. The CTs don't move under this circumstance. And now you see the echocardiogram moves. And then, because I think most people are going to look at this on the phone, they are going to see the image live filling the whole screen so that you can look at that on your phone easily. Just one example. Okay, thank you very much for that time, Grace.
This is really good. I really like this book and these images. I think there's no www. I think that's md1world.
Yeah.
.com. I think that's it. Yeah, that's it,
yeah.
Guys. Without www. That's what I have from my phone.
So next week, Grace, we're going to talk about corrected transposition.
Yes.
And Norman is going to be with us, and Alan is going to be with us.
Yes.
And we're going to have Natasha Khan, who is going to be presenting the surgical approach from Birmingham, and Diane and I will be doing the anatomical introduction.
Good. Thank you very much. Great session as usual. Thank you, everybody.
Thank you.
Guys, thank you very much.
Okay. Bye.
Okay. Bye.